Hello everyone. Today I will be discussing about intracranial hypertension. The intracranial hypertension is the major cause of all the complications in neurosurgical patients. And the main aim while going for neurosurgery is one of the main aim is to reduce the intracranial pressure. So aim of this presentation is to define when we say it's intracranial hypertension, what are the physiology and causes behind it, how to diagnose and treat it. Intracranial hypertension is a condition with high pressure exerted on the brain. Normal intracranial pressure is 5 to 15 millimeter of mercury, or we can say 20 centimeter of water. So intracranial pressure more than 15 millimeter of mercury or more than 20 centimeter of water is considered as intracranial hypertension. Intracranial hypertension is graded according to the pressures. It is mild when it is between 16 to 20 millimeter of mercury, moderate when 20 to 30 millimeter of mercury, and severe when it is more than 30 millimeter of mercury. The physiology or the reason behind intracranial hypertension can be explained by Monro-Kelly doctrinal hypothesis. It states that sum of volume of brain, CSF, and intracranial blood is constant. Any change or any increase in any one of the component causes rises in intracranial hypertension. Small volumes can be compensated in the brain, but as you know, brain is a fixed or skull is a fixed space. So any increase in any of this component in form of bleed, mass, edema, it has to be operated upon to keep the ICP down. To talk more about how the intracranial pressure increases, we should know the cranial contents. The cranium is full of brain, 1300 to 1750 ml. Tissue is there, 300 to 400 ml. Blood is around 100 to 150 ml and CSF 100 to 150 ml. This schematic presentation nicely shows that normally we have around 80% of the brain tissue, 10% blood and 10% CSF. If for any reason there is an increase in the brain content, like in cases of tumor, because of mass, then either the blood flow will be reduced or there will be pressure on the CSF. And as soon as the pressure increases, the blood flow to the brain and the CSF production, everything decreases and causes effect. The cerebrospinal fluid is secreted at the rate of 500 ml per day by the choroid plexus in the lateral ventricles. It flows through the ventricular system and exits the subarachnoid space through foramen of Melinda and Nushka. Any obstruction to this flow will lead to hydrocephalus and increased pressure. And the cerebral blood flow, it depends upon the pressure and the resistance to the flow. The cerebral perfusion pressure depends upon the systemic pressure and the intracranial pressure. And it's a difference of mean arterial pressure and the intracranial pressure which results in the cerebral perfusion. And cerebral blood flow is directly proportional to the cerebral perfusion pressure and inversely proportional to the cerebral vascular resistance. If the resistance is more, then the blood flow to the brain will be less. The blood flow to the brain is maintained by the cerebral autoregulation. There are normally components like neurogenic, myogenic, vasogenic, endothelial components which determine the flow of blood to the brain. It changes the size of arterioles, venules, which determine the hemodynamic regulation in the brain. In the normal range of mean arterial pressure 50 to 150 mm of mercury, the brain is able to compensate or changes the size of arterioles and venules. But when the mean arterial pressure is less or is very high, then the autoregulation fails and it adversely affects the intracranial pressure. This diagram shows when the volume of brain is less, the intracranial pressure is more. When there is an increase in the volume of the brain, to some extent the skull is able to compensate without much increase in the intracranial pressure. But when there is a beyond the threshold level, even a small increase in the brain volume causes a significant rise in intracranial pressure as a skull is a closed space. So any increase in the brain volume after threshold level, it suddenly increases the ICP too much. So intracranial hypertension is classified whether depending upon the cause, whether it is because of the parenchymatous intracranial hypertension or is because of vascular causes or intracranial hypertension caused by disorder of cerebrospinal fluid dynamics or idiopathic intracranial hypertension. Whenever there is a parenchymatous involvement, like acutely in cases of hematoma, subdural hemorrhages or extradural hemorrhages, then there is the intracranial hypertension. Or chronically in tumor, slowly the tumor is increasing in size and it's raising intracranial hypertension. Cerebral abscess again, it's a subacute thing more of causing raising the intracranial hypertension. Vascular intracranial hypertension occurs whenever there is a brain edema due to brain congestion, followed either by increased cerebral blood volume, which is caused by increased flow of blood, or by reduction or stoppage in the cerebral blood outflow. This happens in diseases like cerebral venous thrombosis and superior sinus thrombosis, or an extracerebral disease like hypertensive encephalopathy or cerebral venous outflow reduction. Then the third major cause is intracranial hypertension caused by CSF dynamics. Whenever there is overproduction of CSF or there is a less drainage of CSF, then it causes intracranial hypertension. The obstruction to the CSF circulation occurs in cases of tumor, hemorrhages, acute stenosis, when they obstruct the outflow of CSF from the brain. The apparent mechanism is occlusion of arachnoid villi produced by blood and inflammatory mediators. Cases of reduction of CSF absorption in case of acute meningitis, subarachnoid hemorrhage or sarcoidosis also causes intracranial hypertension. Then the fourth main cause is idiopathic intracranial hypertension. Before it was known as pseudotumor cerebri or benign intracranial hypertension. This is defined when there is a raised intracranial pressure but we don't have any intracranial region or any definite cause. But it happens due to endocrine, metabolic and hematological diseases or hormonal treatments. The main symptoms of intracranial hypertension are headache, visual loss and visual defects, signs of papilledema, visual field defects. There is diagnostic criteria when we say it's an idiopathic intracranial hypertension, and the criteria is when the CSF pressure is more than 25 centimeters of water. Normal CSF study is there, like CSF proteins, cell count, glucose, they all are normal. So you don't have a definite intracranial pathology or any infection which suggests rise in CSF pressure. then symptoms should be there of raised intracranial pressure, and CT or MRI should show a normal cranial state. When these criteria are fulfilled, then we say that this intracranial hypertension is because of idiopathic causes. Now, symptoms in general for all the intracranial causes of intracranial hypertension are headache, which is the most common sign, or most common symptom. Changes in eyesight, such as blurry vision or double vision. Vision loss, especially in the peripheral vision. Patient feels dizzy, vomiting, neck stiffness, trouble in walking, tinnitus, forgetfulness, and even depression. The signs of intracranial hypertension are when there is a visual field defects, blind spots are there on visual field test. Thermoscopy we find there is a capillary edema. And thirdly is that when we measure CSF pressures. So in all, we cannot diagnose intracranial hypertension until we have symptoms and signs, we have imaging to prove it, and or we have measured intracranial pressure to say that the patient has intracranial hypertension. Now there are few scans which I am showing you, which shows our raised intracranial pressure. Here, if you see, there is a posterior fossa tumor which is obstructing the outflow of the CSF, resulting in increase in the size of the ventricles, causing a obstructive hydrocephalus. Second, this one scan shows a benign intracranial hypertension. There is no obvious intracranial pathology. You don't see any tumor, any edema, infarct, but ventricles are dilated. There is a hydrocephalus is there. And if we have done a CSF study, it's a normal. So this will suggest that this patient has benign intracranial hypertension. This scan shows a case of subdural hematoma in a patient. If you see on the left side, the ventricle is compressed, the right side, the ventricle is open. There is sulci gyri are obliterated here, you cannot see, but here you can see sulci and gyri. You can see here sulci and gyri, and there is a mild midline shift in this case. Now, to measure the intracranial pressure, you need an intracranial pressure monitor. The ideal intracranial pressure monitor should cause minimal trauma during placement. Negligible risk for infection should be there. No CSF leakage should be there. Easy to handle, reliable, able to continue to function during various diagnostic and therapeutic procedures. And there is no ideal ICP monitor as such. Intracranial pressure monitoring can be done either by non-invasive or invasive techniques. Non-invasive techniques are transcranial Doppler, optic nerve sheath diameter, tympanic membrane displacement, CT scan, MRI, fundoscopy. And invasive techniques like ventriculostomy and transducers. I will discuss one by one the various techniques. Transcranial Doppler is a non-invasive method of measuring intracranial pressure. In this we measure the blood flow velocity in the middle cerebral artery, and the systolic and diastolic flow velocities are measured, and the deviation or changes in that helps to give us a possible ICP reading. We can just correlate in transcranial Doppler with the blood flow velocity how much ICP, whether it's raised or not. We cannot get a definite value of ICP from transcranial Doppler. The other limitation of transcranial Doppler is it's operator dependent and results vary in traumatic brain injury to hydrocephalus and stroke. Other non-invasive method to measure intracranial pressure is optic nerve sheath diameter. Normal optic nerve sheath diameter is less than or equal to 3 mm. When it is more than 5 mm, we consider that the intracranial pressure is raised. It's again a quick, efficient surrogate marker of intracranial hypertension. It does not give us exact value of intracranial pressure. The limitations to optic nerve sheath diameter measurements are presence of any tumor, inflammation, sarcoidosis, or Graves' disease. Especially if the patient is optic nerve is affected or there is lesion in the orbit, then it is impossible to measure the optic nerve sheath diameter. The other non-invasive method is to measure tympanic membrane displacement. Tympanic membrane displacement is measured in response to sound stimulation. It causes contraction of stapedius muscle and movement of the stapes. Pressure changes resulting in the movement of stapes and displacement of tympanic membrane gives us a rough idea whether the ICP is raised or not. Again, the limitation is the patient should have a normal middle ear function. Any middle ear disease or infection can affect tympanic membrane displacement. The other non-invasive method is to see the MRI study with a motion-sensitive blood flow, like pulsatile, arterial, venous, or CSF flow during the cardiac cycle. But the limitation of this is selection of representative image slides and which blood vessels are chosen to study. We can't assess ICP levels, we just can get an idea that it might be or may not be raised. To get a definite ICP measurement, we need to have an invasive intracranial pressure measurement technique. Depending on the technique of measuring ICP in various locations, like either in interventricular space, intraparenchymal, epidural, subdural, subarachnoid, or lumbar CSF, we can use various catheters, bolts, screws. If the catheter is in the ventricle, it's called interventricular CSF pressure monitoring device. If it is a subarachnoid space, epidural, intraparenchymal, or subdural space. All of these give an accurate value of intracranial pressure. Among all these, intraventricular catheter is the most accurate monitoring method. And to insert an interventricular catheter, you need to drill a bulb hole through the skull, and the catheter is inserted into the lateral ventricle. By interventricular catheter, there is another advantage that it can be used to drain fluid if there is an interventricular hemorrhage, or the CSF pressure is raised, or there is a hydrocephalus. You can move the CSF or fluid forward. But there is a complication like while inserting drilling hole, while inserting the catheter, the hemorrhage can occur. The infection in form of meningitis or ventriculitis can happen. In the subdural space, also we have to drill a hole and we put a subdural screw or bolt. It allows the sensor to record from inside the subdural space. The epidural sensor again, a bud is to be made in the skull. The procedure is less invasive than other methods, but we cannot remove CSF through the epidural sensors. Then, while measuring the intracranial pressure, we see the intracranial pressure waveforms. This graph shows the normal intracranial pressure waveform. In this P1 is the arterial pulsation. P2 comes because of brain compliance, and P3 comes because of a aortic valve closure or some diacritic notch. If the P2 wave is bigger than the P1 wave, then we say that there is an increased intracranial pressure. Our compliance is, brain tissue compliance is reduced. When there is augmentation of P1 and there is a steep rise in P2, then it is a critically or severe intracranial hypertension. You can get waveforms in case of low systolic blood pressure. You can have a low small P1, but in this if you see P2 will not be big. Or in case of high systolic blood pressure or hypertensive emergency, you might find a steep rise in the P1. Then there are Lundberg ICP waveforms, in which intracranial pressure is measured in relation to time. In this, the waveforms of the CSF are monitored, and a steep increase in ICP lasting for 5 to 10 minutes, if you see here, suggests it's a pathological condition and suggests severe intracranial hypertension. These are called Lundberg A waves. Lundberg B waves are oscillations of ICP at frequency of 0.5 to 2 waves per minute, and they are possibly because of result of cerebral vasospasm. And Lundberg C waves are oscillations with frequency of 4 to 8 waves per minute, and they are present in the normal healthy subjects. The other method to measure CSF pressure is by lumbar puncture CSF opening pressure. It's again a surrogate marker, but very less non-invasive procedure. In this, lumbar puncture is done in lateral position, because if you do sitting position, you see a higher pressures. Normal value is 10 to 15 millimeter of mercury or less than 20 centimeter of water. Precaution is again, while doing the lumbar puncture and you expect the pressures are high, don't overdrain the CSF. Then overdrain of CSF can cause tonsillar herniation or brain herniation. As soon as you remove the stellate from the lumbar puncture needle, it should be connected to the pressure transducer to get a opening pressure reading. This will help you to give almost correct intracranial pressure reading. This is mostly used in idiopathic intracranial hypertension. Even you can do a guarded LP to remove some of the CSF to reduce the pressure in the brain. The complication of intracranial pressure monitoring, mostly invasive monitoring, are infection, intracranial hemorrhage or hematoma, CSF leakage, mechanical failure or blockage, or overdrainage of CSF. Once we have diagnosed and seen that the patient has got intracranial hypertension, now the next thing is how to treat it. First thing is increase the cerebral venous outflow. As we know that the brain tissue, blood and CSF, they cause increase or maintain a certain intracranial pressure. So we have the best or easiest way is to make it head up 30 degrees so that there is a cerebral venous outflow. Don't keep high peak, and increased intracranial pressures should not be more because they cause decreased cerebral venous outflow. Try to maintain cerebral perfusion pressure and brain tissue oxygenation. Avoid hypoxia and hypercapnia as they cause cerebral vasodilatation and increase intracranial pressure. High PEEP to maintain oxygenation hinders cerebral venous outflow. But again, you have to see the practicality if there is a polytrauma patient, the respiratory failure. then you have to see whether IPP is required or not. Then it depends patient to patient, condition to condition. But in general, don't keep high peak to maintain oxygenation. Avoid hyperthermia or fever in the patients because increase in the body temperature results in increase in the basal metabolic rate. For every 1 degree rise in the Fahrenheit rise in body temperature, the basal metabolic rate increases by 7%, causing increased blood flow to the brain. And this causes increasing intracranial pressure. So use antipyretic agents, cold sponging in the patient to control hypothermia. Prevention of seizures is another important thing because patients with an intracranial pathology have high chances to get seizures. And seizures increase cerebral metabolic rate and intracranial pressure. Use anti-epileptics to prevent seizures like phenytoin, sodium valproate, levetiracetam. Heavy sedation and paralysis can be used to prevent agitation, posturing, or coughing in the patient. Non-depressing muscle relaxants are not required until we are not able to control the patient with deep sedation, and muscle relaxants should not be given over long period of time. Try to control the agitation, posturing, coughing by sedation. Avoid muscle relaxant as much as possible. These are just for the last resort. And sedatives and muscle relaxants can be taken once a day, usually in the morning to allow neurological assessment. Now, of these, after these non-pharmacological measures, we should be using some pharmacological measures to reduce the ICP. That hyperosmolar therapy is the mainstay. Mannitol is the most commonly used hyperosmolar agent for the treatment of intracranial hypertension. Hypertension can also be used because for a long time we have been using mannitol. So most of the studies, literature supports use of mannitol, but hypertension is equivocal in reducing the intracranial hypertension. Mannitol reduces ICP in 1 to 5 minutes with peak effect at 20 to 60 minutes. The effect of mannitol lasts 1.5 to 6 hours depending on the clinical condition. Hypertension can also be given in the range from 3% to 23.4%. All these hyperosmolar agents act by drawing water from the interstitial space of brain parenchyma into intravascular compartment and in the presence of intact blood-brain barrier, and it reduces intracranial volume and intracranial pressure. If we are ventilating the patient, we should hyperventilate, decreasing the partial pressure of carbon dioxide, which causes constriction of cerebral arteries by alkalizing the CSF. This results in reduction in cerebral blood volume and decreasing the intracranial pressure. Barbiturate coma should only be considered for patients with refractory intracranial hypertension. The mechanism of ICP reduction by barbiturate is unclear, but most likely it is because of reduction in the cerebral blood flow and the cerebral metabolic requirement of oxygen, which causes immediate reduction in the intracranial pressure. Steroids are used only in the cases when there is edema due to the tumors or due to the vasogenic cerebral edema cases. In brain hemorrhage, trauma, we don't use steroids. Focal neurological signs and decreased mental states owing to surrounding edema improves within hours. Increased ICP when present decreases over the 2 to 5 days with the use of steroids. Most commonly we use dexamethasone in the patients. The patients might have intracranial lesions like form of tumor, hemorrhage, hydrocephalus, that we need a surgical intervention. Whenever there is any mass, then intracranial mass should be removed to reduce the intracranial pressure. If there is any acute epidural or subdural hematomas, then this should be removed immediately because the bleeding has to be controlled and the ICP has to be reduced. CSF drainage also lowers ICP because it reduces the intracranial volume, and it is done with the help of ventriculoperitoneal shunt, which is the most commonly done thing. If brain is diffusely swollen, the ventricles may collapse, and this modality in that cases have a limited utility. In the patients where the pressure is too high, like after removing hematomas or surgery, still the pressure is high, in that we create a cranial window, a cranial vault, and part of the skull is removed, negating the mononuclear doctrine of fixed intracranial warning and allowing the swollen brain to permeate through the bone window and relieve pressure. Like in this CT scan, you can see that skull is removed and the pressure on the side of the brain is relieved by movement of brain outside the skull window. So, in general, or in short, how to approach a patient of intracranial hypertension is determined by signs symptoms of intracranial hypertension, do a imaging. If imaging shows some trauma, hematoma is there, tumor is there, surgical evacuation is required. If intracranial pressure monitoring shows high ICP, again surgical evacuation or CSF drainage is required. Use various ways like head elevation, airway ventilation control, sedation anesthesia, control of hypothermia, hypertension, prevent seizures, use sedation paralysis, hyposmolar therapy, hyperventilation, barbiturate coma to control the ICP. In case of uncontrollable ICP, do decompressive craniectomy. Thank you.